Hello, everyone. My name is Monica Mallampalli. I'm the president and CEO of the Alliance of Sleep Apnea Partners. We are a national nonprofit focused on helping individuals who are living with sleep apnea. Welcome to today's session. We will be discussing about the connection between obesity and OSA, which is obstructive sleep apnea, and we're very much want to hear from you as well as our experts today. So please join us in this conversation. Um, this week, we are celebrating Sleep Apnea Education Week. We started on Saturday, April 18th, and it ends on April 26th. Please engage with us on social media. And the whole idea of the Sleep Apnea Education Week was to increase education and awareness around sleep apnea. The focus of this year's Sleep Apnea Education Week has been on partnerships. And with this webinar today, we want to focus on two of our partnerships with the Obesity Action Coalition as well as the Gerontological Society of America. Briefly, I do want to mention that obesity and obstructive sleep apnea are tightly connected. There is a bidirectional relationship between these both diseases, and you will hear more about that from our panelists as we, talk about this topic. But before I begin, just brief housekeeping. If you have any questions, please add those to the Q&A and not the chat. That's where we will be looking for questions from you. Just want to reiterate that if you're looking for evidence-based resources, go to our website, apneapartners.org. I also encourage you to go to OAC's website as well as GSA's. And those we will share those links with you. You can also access American Academy of Sleep Medicine, and they have good resources as well. So I'm going to get started by inviting our panelists. So I want to first invite my co-moderator today, Ophira Bansal. Ophira is the Strategic Alliances Program Manager at the Gerontological Society of America, or GSA. Welcome, Ophira. It's the nation's largest interdisciplinary organization devoted to the scientific study of aging, advancing evidence-based policies and practices that support healthy aging across the lifespan. In her role, Ophira manages the development and production of strategic alliances programs with her colleagues, developing a variety of innovative resources aimed at enhancing person-centered care for and life of older adults. Obesity is one of Strategic Alliance's division's largest areas of focus. Other areas include brain health, vaccines, and ageism in healthcare, to name a few. So great to have you here, Ophira. Do you want to add anything else regarding GSA?
Oh, thank you. As you already mentioned, the GSA is a multi-interdisciplinary organization, a membership organization, and we have a variety of interdisciplinary studies, clinicians, researchers, everything from AI to zoology. So anything that touches aging, we have members who are interested and focus on that.
Oh, fantastic. Let's go ahead and invite our next panelist, Sarah Bramblette. Sarah, welcome. Sarah is the Senior Advocacy Manager at the Obesity Action Coalition, or OAC, and brings decades of advocacy experience focused on improving diagnosis, treatment access, and insurance coverage for obesity, lymphedema, and lipedema. She combines personal lived experience with deep policy expertise to lead OAC's advocacy efforts. I'll also go ahead and invite Dr. Mira Tadros. She's the Clinical Assistant Professor of Medicine in the Division of Pulmonary Critical Care and Sleep Medicine at the Icahn School of Medicine at Mount Sinai. She's the director of the Mount Sinai's Obesity and Sleep Program and is board certified in both sleep medicine and obesity medicine. Her work emphasizes the bidirectional relationship between metabolic health and sleep and includes thoughtful use of emerging therapies such as GLP-1 based medications. Welcome, Dr. Tadros, and I'm sure we'll have a lot of questions around GLP today. And next, I want to invite Dr. Brian Wojcik. He is the assistant professor of medicine in the section of endocrinology at Yale University. Dr. Wojcik completed an internal medicine residency at Mayo Clinic and pursued subspecialty fellowships in both sleep medicine and endocrinology at Yale. With additional training in obesity medicine, Dr. Wojcik specializes in comprehensive weight management and focuses both clinically in research on the intersection of obesity, diabetes, and sleep disorders. All right, welcome everyone. And before we get started quickly, I just want to mention a couple of things and then we'll get into the discussion. Obesity and sleep apnea, like I mentioned, are both chronic diseases and they're very much interrelated. And that's the theme sort of you will also hear today. Again, there is a need for patient-centered care and especially interdisciplinary care. That's why we have our two panelists who come sort of from two different, sort of one trained in sleep medicine, pulmonary critical, and one trained in endocrinology, bringing sort of their expertise to address this topic. While everybody is affected, all adults are affected by obesity and sleep apnea, there are certain risks and challenges that increase with age, and we'll sort of touch upon that as well. Once again, I want to remind everyone, please add your questions to the Q&A. All right. Dr. Tadros, let's just get started with you quickly. From a clinical perspective, can you explain this biological and physiological relationship between obesity and obstructive sleep apnea? And how do these conditions worsen over time?
Yeah, of course. And thank you for having me. It's always exciting when we have an additional treatment option added to our toolbox here. So obesity and sleep apnea actually have a bidirectional relationship. So they both affect each other and can worsen each other over time. We'll start by how obesity contributes to obstructive sleep apnea. So as a quick reminder, obstructive sleep apnea is when the upper airway narrows or collapses during sleep. So with obesity, if there is excess, what we call adipose or fat tissue, depositing either in the airway, which could be in the tongue or around the airway, that can put pressure on the airway and contribute to collapse. Not only in the upper airway, but if adipose tissue or fat tissue deposits around the abdomen, it can actually put pressure on the diaphragm and the lungs. And when the lungs are not allowed to expand fully, the airway is less stable and more prone to collapse. So those are some of the most better understood mechanisms. There is also an additional role for inflammation. So we know that fat tissue sometimes releases substances that can cause inflammation in the body. And if there is also inflammation in the muscles that keep the airway open, that can contribute to airway narrowing or closure. Now, going the other direction, obstructive sleep apnea can actually worsen or promote weight gain. The reason being is with sleep apnea, a patient can experience fragmented sleep, intermittent drops in the oxygen level throughout the night, and that poor quality sleep can actually have hormonal consequences, more notably increases in hunger hormones, a hormone called ghrelin, which is, we know can increase with untreated sleep apnea, which leads to increased appetite, craving for even higher caloric foods. And not only that, if you can imagine with sleep apnea, there's significant fragmented sleep, which results in daytime fatigue and sleepiness. And with that daytime fatigue and sleepiness, it makes it harder to stay physically active or to have, energy to do things. So over time, it sort of just becomes a cycle where the airway obesity can contribute to airway collapse, sleep apnea leading to poor sleep, hormonal changes, fatigue, causing further weight gain, and maybe worsening of the sleep apnea.
So this is that vicious cycle we talk about. And both these diseases tend to worsen with age, right?
Yes, especially we know with sleep apnea, the muscles can sort of relax more, lose their function with age. And I know Dr. Wojcik will also touch on her sort of gender differences as well, but yes.
Fantastic.
Monica, if
yes.
I may, I have a question for you.
Sure.
We know that obstructive sleep apnea and obesity are highly prevalent in older adults. Can you share what the most recent data shows about the prevalence of these conditions and how they affect older adults differently from younger population?
Yeah, so we know that estimated at least globally, there are 1 billion people living with sleep apnea, but within the United States, we think it's 54 million plus. We don't have the exact prevalence number. It can be as high as 80 million. And obesity, I think, is close to at least 100 million from what I have seen. So I think both are very prevalent. And as Dr. Tadros said, it does increase with age for both, especially with sleep apnea. That's what we've seen. We don't have exact prevalence, and I'm not sure. I would love to hear from the experts of people living with both these conditions, right? But we do know some numbers. So we know about 70%, at least that what we have found, are individuals with obesity in the United States have some form of obstructive sleep apnea. And about one third of people with obesity have moderate to severe sleep apnea. So there are some numbers there, but I think I don't know how accurate these numbers are. We're hoping, I mean, we'll see again if we get more clarity on this. But the rates also differ by race and gender. So that's something, again, we know in certain populations, it's more common. And then again, you did ask about older adults differently, and I think there is what I wanted to say was what Dr. Tedros talked about is the physiological differences that we see as people age. And a point I do want to make is sleep apnea can be caused by anatomical differences as well as physiological differences. And I think this is that inflammation and physiological changes that we are seeing in link to the obesity. But not all people with sleep apnea, or I should say, not, there is that anatomy that plays a role in there as well. So again, we can't just assume that everybody who is obese has sleep apnea, or everyone with sleep apnea will be obese, but there are certain risks there. Anything the experts want to add to that?
Sure. The sleep apnea. So first of all, obesity as a disease is heterogeneous, meaning that there's probably different kinds of obesity, right? And the same is true of sleep apnea, right? There's different kinds of sleep apnea. It has different components. So the truth is that weight loss is one tool in the toolbox, and it can be pretty effective in the exact right patient. But we don't have a great way of predicting that patient. And the other thing is that these medicines are variable in function, so we never know how effective it is. But these are heterogeneous diseases that really affect people differently, and there's a lot of variety of disease. So even though it's sleep apnea, it's not one kind of sleep apnea. There's many different kinds of sleep apnea out there.
Thanks for clarifying that. Let's talk to Sarah. Sarah, tell us a little bit about your lived experience with both obesity and sleep apnea. And again, how has navigating the healthcare system shaped the way you advocate for others today?
Sure. So I've lived with obesity my entire life. And I was in my mid 20s, I call, when I was diagnosed with sleep apnea. And that diagnosis came at a time when I was trying to improve my health and I was seeking bariatric surgery. So it was kind of part of um, that process for approval and things. So that was in my 20s. And so I was diagnosed with sleep apnea and I got the CPAP machine. And after I had bariatric surgery and I was losing a substantial amount of weight, I did notice like I was taking off the mask overnight. And while a lot of people in the community just like stopped use on their own, I knew like it was best to go and get a new sleep study. So I did that. And at that time, it indicated I didn't need the CPAP machine. And so years later, so actually hearing that it clicks with age is kind of actually something new for me. So hearing that tonight, I'm like, oh, this makes a little more sense. But again, since both of them are chronic conditions, with obesity, things definitely changed. I have some other conditions that contribute to my weight because, as Dr. Wojak said, obesity is not all the same either. So I found a time years later where it was thought that maybe sleep apnea I'd redeveloped it, and I had a study done that showed it wasn't. But then I was also having some cardiac issues with arrhythmias. And so it was suggested to have another sleep study to test that. And it indicated that using CPAP again would be beneficial to my health. And so I started to do that again. I think so navigating just that journey of that just really helped me understand advocating for myself and asking for new things. But I mean, the whole journey with living with the chronic disease of obesity has taught me to advocate for what I need and ask for, because I think there's, we don't always have access to the care we need because of various barriers. So just really, sometimes people with obesity don't think we deserve the care, or people just tell us like, go lose weight, versus actually giving us the tools to do that. And so I think we have to really demand like something's not right or we don't feel well. I mean, I know I would hear from, when I was younger, college roommates or my siblings, and we'd go on vacation and they'd say like, oh, you snore so loud, I don't want to share a room with you. And of course, sometimes it's just a joke. But then when you find out like that's one of the major signs of having sleep apnea, and then when you have a CPAP machine and you start traveling with it with the same group of people, and they're so thankful that you have this treated, it's very beneficial. And I have friends who I later in life are only now getting screened for sleep apnea and getting diagnosed, and they say, oh my gosh, I'm getting the best sleep of my life, I wish I've known this sooner. And to me it's a little concerning. As I mentioned, I was screened as part of seeking care for obesity, but I think it's being missed, screening people who might be at risk. I think it's something that's very overlooked. And I feel like, even though it's something as people might develop more as they're aging, I think people are really being left behind of getting the care they need for that, just overall improved health, improved metabolic health, and just a better night's sleep, which I think everyone could agree that is needed these days for many of us.
Thanks, Sarah. You certainly hit upon some important points there. First of all, the messaging that the doctors are giving or anybody is saying about simply it's all about losing weight, as well as the fact that you talked about self-advocacy, because I think that's something we at ASAP encourage self-advocacy. And I think this power to patients speaking up and asking questions and about their health. Dr. Tadros and Dr. Wojcik, do you hear similar stories or concerns from patients who come to your clinics?
Yeah, and certainly one of the things that I've noticed at least is, women do present differently from men sometimes in regards to symptoms. So it's not always, like snoring can certainly be part of it, but they might not have like the significant, like loud snoring or gasping or choking. And sometimes that's not something that people think of for women. They can be more fatigue, more like fragmented sleep. So certainly paying attention to one's sleep is important because sometimes the symptoms can be a little bit more subtle than, like I said, loud snoring.
We've got a
Dr.
couple
Wojcik.
of questions in the chat, if I may. There's a question on whether GLP-1s help with sleep apnea, and if that's the case, why is it difficult for them to have their insurance company cover the GLP-1?
Sure. So I'll take this one. GLP-1s help with lots of things. So they are FDA indicated. So Zepbound specifically is FDA indicated for sleep apnea, but it's also FDA indicated for just obesity. And we have a lot of trouble getting it covered. This is a function of someone at the insurance company, basically doing the math and saying they don't want to cover it because it costs too much. The truth is that this is in large part because our insurance infrastructure is fragmented. So individuals that are treated for these disease processes do get a benefit long term, and there have been analyses that show that it's cost effective. The problem is that people switch insurance, and so the insurance company doesn't get the benefit of paying for it, so they don't want to pay for it. it's broken and frustrating. And I assure you, both me and Dr. Tadros fight for our patients all the time. We write a lot of appeals. But yes, it's frustrating. It's very appropriate to get started on these medicines. If I had to guess, it's someone at the company did some math and said it's not worth it to us.
Thank you. And there's a question concerning the type of training that clinicians and providers receive in diagnosing OSA, and if the lack thereof could cause lower referrals to sleep studies and sleep clinics.
So I'll fill the void again. I would say in terms of sleep medicine is a subspecialty, right? So we do have a unique skill set. Sleep apnea as a disease is incredibly underdiagnosed. All right, we know that there's great data to show that this is underdiagnosed, and also I hate to blame physicians, especially primary cares that are managing everything, right? Those are the quarterbacks. They really are responsible for taking care of patients. So it might not be that they're poorly trained, but they just have so much to do. I do agree that we do need to screen more patients, and I'll be honest with you, since the advent of some of these new medicines, we've been actually getting more influx. And to some degree, it's also we just don't have enough. There aren't enough physicians trained in sleep medicine, because it's not that our clinics aren't full; they're very full. We don't have enough people that are trained in this skill set to manage the people that are being referred. So that's part of the problem too. So I think it's both sides, but I wouldn't say that the physicians are untrained. I think they're probably managing so much that they might not see this one piece.
Thank you, Dr. Warshak. Since we already have you on the hot seat, I've got another question for you.
Sure.
Can you walk us through how obesity, insulin resistance, and sleep apnea are interconnected, and why it's important to treat these conditions together rather than in isolation?
Sure. So all of this is really interrelated. I find it fascinating. It's the focus of a lot of my research. Obesity. So obesity is probably is the driver of many of these things. As you gain weight, as individuals gain weight, they have more insulin resistance, and insulin resistance causes a lot of things, right? It causes increases in blood sugar. It affects your cholesterol. It affects things like fatty liver disease, and it also worsens things like obstructive sleep apnea. It's affected in really specific ways, increases airway collapsibility, and affects how we respond to carbon dioxide. When individuals have sleep apnea, it does affect their glycemic outcome. So it does affect their blood sugar. People that have apnea tend to have worsened blood sugars. All right, they've done really nerdy scientists have actually caused hypoxia in patients. All right, so they've made them have low oxygen, and then they did something called a clamp study. But basically, they looked at insulin resistance by saying how they processed glucose, and patients that have low oxygen levels process glucose worse, right? So I think one of the primary mechanisms that affect insulin resistance from sleep apnea is hypoxemia, or low oxygen because of it. So that's a really important piece. So both obesity and sleep apnea affect insulin resistance, which is kind of the bad outcome that comes from obesity. And it causes all these other things like diabetes, affects fatty liver disease, affects lipids, which is the cause of like heart attacks and strokes. So So both of those have important effects on that from that standpoint. In treating these things together, so treating obesity obviously has important effects on sleep apnea, and sleep apnea has important effects on obesity, as we mentioned to Dr. Tadros, as mentioned by Dr. Tadros. And both of these things actually also have some effect on insulin resistance, right? So it's kind of this, they're all interrelated for those reasons, right? You have both hormonal effects and the hypoxia, I think particularly the hypoxia has an important effect on insulin resistance in patients.
Just as a follow-up question, so if somebody, especially, I mean, there is also the genetic component to having sleep apnea, right, in families, and including some of these chronic diseases, is it worth for the patient to even have the conversation with their doctors to see potentially, knowing a family member has sleep apnea, whether they're at risk for sleep apnea or if they have, the risk for diabetes, at least have that conversation? How do they go about that?
I mean, so I'm always always a fan of patients advocating for themselves. And as I mentioned, the medical systems can be overstressed and overwhelmed. I have the good fortune of being at an academic institution. I can take time with my patients, but it's not everyone, right? And so if you see something that's unusual, right, I feel like you need to tell your doc about it. I think it's very reasonable to say if you think you're at risk of sleep apnea, you should tell someone about it. If you're worried about your risk of diabetes, by all means bring it up, and it's worth a discussion. We know that patients with type 2 diabetes are at more risk, and with a family history of type 2 diabetes are at higher risk than those with type 1, right? Because the type 2 diabetes is polygenic, it has a lot of pieces. So it's worth bringing up that family history. Now, whether it shows up in that patient or not is a question, but it's worth a test, right? If you're looking good, then great. Well, we are, as physicians, we are always happy to give you a high five, right? And say, you're doing great. And if you're not, well, by all means, we need to treat it.
Absolutely. Thank you for that. Ophira, let's get through the questions. I think there are quite a few questions coming in.
Great. We have, how does stigma and weight bias affect supportive care for patients with obesity and sleep apnea when a person is struggling?
Can take this one. I mean, if I will, because I want to highlight the kind of follow up on the past question about the coverage for GLP-1s. I think that is what is the weight bias is what's rooted in a lot of these insurance decisions. It's not just not wanting to cover it, but because insurance companies can get by with not covering obesity treatments because it's not mandated, they can easily also deny when it's obesity and sleep apnea, even though it is indicated, and technically they shouldn't be able to deny for sleep apnea, but they do, and they expect patients just to not fight back. So that is where we do need to self-advocate. I'm very glad the doctors here do help and appeal for their patients. But I think, as I mentioned, the assumption that if you just lose weight, it makes everything better. I mean, we're often told that for any ailment we have, and that's not the case, or the fact that you can't lose weight instantly. So perhaps we need some treatments for our other conditions as we work on possibly weight or weight management. And also, while we now have great treatments for weight management and obesity, it's not going to completely result in a typical BMI. There's people with a typical BMI who have sleep apnea. So the idea that if you just treat obesity or lose weight, it'll just make everything else better. That's not the case. And that's why we have to advocate for ourselves to get tested and screened for these other conditions. And as mentioned, treat them together and not separately. And if I can just real quick, when it is mentioned of if the GLP-1s work, I will share again personally. So I do use a CPAP for sleep apnea. And then I've also been able to have access to a GLP-1 for sleep apnea. That is the only way my insurance would cover it. I mean, I did have to kind of fight that a little bit. I think they kind of know me by now, so they didn't fight me too hard, but I had previously won against them. But it's interesting if anyone who's the doctor mentioned, kind of a nerd, and if you use the app that comes with your CPAP machine. So I very much always check to see how I did, what my, AHIs were. And it was interesting that once I started treatment with a GLP-1, that was improving overnight. So I could see that just on my app. And I think that is another reason I've seen patients get denied coverage for GLP-1 because they're using a CPAP. Like that should be their only treatment, where we see these new medications are really complementing that treatment and they're still improving that overall care.
Thank you, Sarah. And there's another question that it fits in with both what you've just said and Dr. Warshak as well, should sleep specialists and obesity medicine specialists be co-managing more patients? And with the introduction of GLP-1s, how frequently should sleep studies be done to see if the weight loss has had an impact on their sleep apnea?
Yeah, so I'll take this one. I think, the use of GLP-1 specifically for sleep apnea was approved somewhat recently. But as sleep physicians, we've known for a long time that weight loss can help reduce sleep apnea severity. So that concept is not new. I think, sleep physicians, we've had great training and management of CPAP and alternative treatment options like oral appliance and ENT interventions. But for instance, for GLP-1 usage, there's been interest. A lot of sleep physicians are adopting it, learning more about it. But there are also some sleep physicians who co-manage with either endocrinologists or weight management specific physicians, or people who have training in obesity. So it can kind of vary. I think, as we've been talking about, it is important to manage both the sleep apnea and the obesity. I'm sorry, what was the other part of the question?
How frequently should this sleep study be done to monitor if the effects of that sleep apnea, if they no longer need the CPAP for the sleep apnea?
Yeah, so there have been quite a few studies looking at the effect of weight reduction and how it reduces sleep apnea severity. 10% of total body weight loss is a number that comes up in a lot of studies. So usually for me, when my patients get to 10% of total body weight loss, we tend to repeat the sleep study. That being said, that number is not necessarily the magic number for everyone. So I've had patients who might lose a little bit less or a little bit more, and there is a change in sleep apnea. So typically 10%, or if there's a new weight plateau, is when I would tend to repeat it. But I definitely recommend repeating it rather than stopping other treatments without repeating a test.
Thank you. And speaking of stopping other treatments, we have an audience member who is 80 years old, and their doctor prescribed modafinil because they complained of lethargy when they woke up, and they were subsequently diagnosed with sleep apnea and have been using a CPAP device for a month. And they want to know what you think about, they're asking their doctor, who's not a sleep specialist, if they should stop their medication.
Yeah, so excessive daytime sleepiness is one of the hallmark symptoms for obstructive sleep apnea. So if I understood correctly, in this situation, modafinil was started prior to the diagnosis and treatment. So a lot of the patients, that's one of the main things that we hope to see improvement in sleep apnea, is improvement in the daytime sleepiness. I would obviously recommend discussing it with the doctor, but yeah, that's one of the big things that we see improvement in. So maybe with the treatment of sleep apnea, that daytime sleepiness has resolved. In some patients, they might still have residual sleepiness, but again, that's less common. So I certainly think it's worth a trial of stopping with the supervision of their physician.
Thank you. And the next question is there a role for nurse practitioners and PAs to be trained in sleep apnea, sleep and obesity?
Sure. Come join us. No, I think that we need more and more people educated on this. Both me and Dr. Tadros are on a national task force that we're both working really hard to get as many practitioners trained and educated, and get more people with this skill set. So I don't think we really care what letters are after your name, right? I think there's definitely a place for everyone, and the more people that are educated and have this skill set, the more people get treated and get the help they deserve.
I just want to echo that. I think as a patient, um, they might be the provider that we see, the frontline provider. They're being more integrated into overall care. I know I see NP at my cardiologist now as follow up in primary care. They're kind of the frontline person. So I think, as you said, anyone who's knowledgeable and can help, refer patients and care for patients is needed. I mean, especially at this time when primary care is kind of at a shortage also. So yeah, I feel like, as you said, more the merrier.
And Sarah, this next question is for you. How would you suggest trying to manage the stress of multiple conditions as both a patient advocate and someone who is experiencing those issues?
I think it's very difficult managing multiple conditions, especially sometimes you have conditions that treatments might contraindicate each other. Now, that necessarily isn't so much with obesity and obstructive sleep apnea, but to just think of like what's your primary concern? It's kind of to say, and I think this is also where a good primary doctor who can be on your team and help lead that team helps out. But certainly understanding, no one's going to be perfect. So, we have we know what we need to do for our chronic conditions. Sometimes a chronic condition might flare. So just knowing what the best you can do when you can do it. And I kind of also want to maybe turn this in to a question too, because I think when it comes to treatment, we talk about CPAPs. When I got my first CPAP, it was, 20 years ago, it didn't seem basic to me, but it didn't have a lot of the bells and whistles that the current ones had. And I used it. I didn't, like I was very much at that time knowing I needed to use it. It made me feel better. So when I guess it's been 5 years now, when I got this new one and it's got the water container and it's got a heated hose and it's got, different masks, I'm kind of like trying to manage all of it. And then the cleaning and everything. And sometimes it can feel overwhelming. And I know patients who like the compliance to it can feel overwhelming. But also I had a home sleep study and then things were just shipped to me. So I've kind of struggled with, is it the best mask for me? Am I getting the best? So I kind of want to, as much as self-advocacy, but also ask the doctors, like, how can we make sure that compliance is because you're like fitted properly, or, how can we troubleshoot those issues that might cause people not to get the optimal treatment that they should be getting?
Yeah, and usually the process or how we recommend for it to be done ideally is, having what we call a setup appointment where the durable medical equipment company has someone who comes to you directly. They put on the mask in real time, teach you how to put everything on. That's the ideal situation. That's usually what's recommended. I know in some situations it doesn't end up happening, which is frustrating. I think, the mask part is a big battle for a lot of patients, especially when first getting started. So usually, at least when I tell my patients you're getting started with it, I'm like, it's not uncommon to need to try a couple of different ones. It's all about trying to find something that's comfortable for you. And trying to like seek help earlier. So that's one of the big things I tell patients, like, don't struggle with a CPAP mask for weeks at a time. If you're having a hard time, let me know, talk to the company. But yeah, initially that period, that's the time to like intervene and make things comfortable. Because when people struggle with it for some time, that can certainly put people off of CPAP, which is understandable.
Thank you. And we have a question stating that there's currently research in Europe that's exploring a potential link between ADHD and sleep apnea, with the suggestion being that in some cases, what appears to be ADHD may actually be undiagnosed sleep apnea, which raises the question of whether some individuals may not necessarily require traditional ADHD medication or treatment if the underlying sleep disorder is properly treated. And so the question is, what is the current perspective in North America, if whether there's a concern that ADHD may be overdiagnosed in some cases where sleep apnea or other sleep disorders are actually the root cause, or is there a consensus that while there may be overlap, these remain distinct conditions requiring different approaches to diagnosis and treatment?
So, so it's a little bit different than the focus of this conversation, but I'm happy to address it. I think so they are certainly distinct disorders, but they can kind of bleed into each other. So ADHD is definitely its own thing, and then sleep apnea is definitely its own thing. There are patients, and I'd say this is more in the pediatric population that present with hyperactivity, right? And so I think the pediatric population is much more likely to be maybe misdiagnosed as ADHD, and in fact it is you find that there is sleep apnea, or there's an overlap there. But I do think that they are distinct disorders that have their own treatments.
Great, thank you.
Actually, I have a question for Dr. Tadros. What are some of the patient barriers that you encounter in your clinic?
Yeah, so I think one thing that can be a barrier to seeking evaluation sometime is if, CPAP is really effective and it works well for a lot of patients, but I've had patients who would have benefited from evaluation, but they tell me, oh, I know if I do a sleep study, I'll end up with a CPAP, and I've been trying to avoid it. So I think it's our job to explore other treatment options. So CPAP, like I said, can be life-changing for many, but we do have alternative options. I think from an obesity and sleep apnea perspective, I think something that Sarah touched on is sort of experiencing weight bias and stigma at some point, whether it's medical care or in the outside world, where I always try to ask my patients first if they're okay discussing weight to begin with, because if they've gotten advice before to just, eat less and move more, that could be frustrating to even discuss obesity. So that's another barrier that sometimes where patients, might not talk about it, but obviously when patients advocate for themselves, and we do have options. And I think one important concept that I always like to explain is we definitely now understand the hormonal mechanisms with obesity a lot more. We know that when patients even work on weight loss, the body, there's this concept of what we call set point or defended weight, where you can think of it sort of like a thermometer where your body's trying to keep you at a certain temperature. The brain has this weight range where it tries to keep you at. So even when patients have success with weight loss, there are these mechanisms that the body does to try to restore to the original weight. So people tend to feel hungrier, metabolism slows down, the body sort of becomes more efficient at conserving energy. So, I try to go over that because it can be validating sometimes to hear, this is complex chronic disease that we should be addressing same way that we address diabetes or hypertension. But I know obviously if patients have had negative experiences before in discussing weight, that can be a barrier to care sometimes.
I'm glad you're having those conversations, because one of the things with Zeb Bond, I would love to hear both of your thoughts, is, the need for lifestyle interventions. Like that's something that, has been encouraged. And is that, again, very common for you to bring that up? And how do you support? I mean, Sarah brought that up earlier too about, the lifestyle, and what other types of support do you provide, when it comes to lifestyle changes?
Yeah, absolutely. And it's definitely is part of overall wellness and health. We recommend, getting enough sleep, dietary changes to support adequate nutrition and exercise to maintain strength and overall health. We ideally, if we try to get the patient access to a dietitian, that might not be possible everywhere, but when that's not possible, just going over, certain handouts or providing some material, and especially when GLP-1s are used, there is a decrease in appetite and decrease in intake. So focusing on what we should be eating when our appetite is decreased. So we definitely try to cover and come up with an exercise plan. So the goal is to sort of provide a holistic kind of approach aside from just, here's the medication.
Like that, Dr. Wojcik?
Sure. Yeah, we have a really comprehensive obesity center. So I'm lucky. I got a lot of resources. My approach is I tend to take a practical approach. First, eating healthfully, and that can be a broad thing. I'm not prescriptive about diets, because the data says that I really shouldn't be, unless I'm really targeting a specific outcome. But there are certain basics. Avoiding processed foods. We know that those foods are designed to hijack our satiety, right? And so starting with cooking your meals and avoiding processed foods is a good baseline, and eating a healthful diet, whatever the kind. If it's a low carbohydrate diet or a Mediterranean diet, I usually, for the most part, don't care. Our patients do get referred to nutritionists. We have nutritionists here, and that deal with advanced nutritional issues. So most patients get a nutritionist. We have a teaching kitchen here, so for patients that need to learn how to cook and there's a point to do this, affordably, right? Our teaching kitchen is staffed by an internist and a nutritionist, that both are chefs, and the point that they purposely choose not to have high cost meals. So that's things you can get at the grocery store. Exercise, I also like to be practical. It doesn't mean you have to go to the gym every time, right? I say do what you love. All right. I'm a snowboarder, so my winter, I'm like, get a winter sport, because winter's hard in the Northeast. But finding something you love and doing it will keeps my patients active. For our complex patients, we have an exercise physiologist, so those that can't do some of those active things. But frankly, I always say with a lot of my patients, because their joints aren't in tough shape, and they maybe they haven't moved as much. I love starting with low impact exercise, pool work, getting on the recumbent bike or the real bike, because that's the way to get started. And so I'm big on that, and finding the things you love to do. And then obviously being thoughtful about getting enough nutrition in, and the proper kinds of nutrition, because we want healthful calories, right? We don't want patients to get malnourished. We want patients to stay strong and maintain bone health and get healthier as they're losing weight. So that's kind of my approach.
Well, that's really fantastic. Thank you for that. Ophira, do you have a question?
Yep. As advocates and professionals treating these complex conditions, again, we said that obesity and obstructive sleep apnea are both diseases. Is there a first place that you would recommend that people go to seek treatment or to get help? Is there a one-stop shop? How do you advise people who are concerned about these diseases?
Yeah, I mean, I think starting with discussing it with a primary care doctor, a lot of primary care clinicians in general, AP and NPs or PAs or doctors are more comfortable now having the conversation. We have more tools, whether it's GLP-1 medications or other tools. There are situations where maybe if there is more complexity, referral to a weight management physician or Sometimes I know endocrinologists like Dr. Wojak have a lot of experience with prescribing a lot of these medications. So there are a few different avenues, seeing a sleep physician who has experience, discussing weight. So it could be a few different avenues, I would say. But starting with the primary care is always, a safe place to start.
That's always the right board answer, right? Like, it's like, it's always like refer to, like, it's never refer. It's like talk to you're the PCP and you have to fix it. So 100% agree. The truth is, I think that every health system is going to be a little bit different, right? There's going to be a pocket in most health systems, especially with the way things have grown with these novel agents, that there's going to be a pocket that's managing a lot of this stuff. Me and Dr. Tadros are lucky to be in these pockets. It's super exciting. It's super fun. It's outcomes are great. It's great to help patients. We love it. But I would say find that pocket. Every health system has this pocket. And so finding that pocket is important, and it's not going to be the same. I echo the statement about primary care being the ones that hold the torch, and they always do. They do all the damn work. All right, they do so much work. And over half of the prescriptions for these medicines were done in the last years. And I want to say 60%, it was a couple of years ago, but definitely well over 50% of these prescriptions are managed by primary care, and it's going to keep being more because they are the front line. And as primary care physicians become more comfortable managing these medications, and they've become much more comfortable over the last few years, they are going to be prescribing more and more of them and being able to manage patients. I would be happy to see every single patient that has these issues, but the truth is there's one of me, right? And our clinics are busting at the seams. So we end up seeing complex cases and most cases, I think certainly more than 50% in the US are managed by primary care.
Thank you for that. And Sarah, from your work at the Obesity Action Coalition, what are some of the biggest challenges people living with obesity and sleep apnea face when it comes to diagnosis, treatment, and insurance coverage?
I think, again, the weight bias that exists in our healthcare system, that is the biggest barrier to care and access to care. I will also say, as I mentioned, also people living with obesity, we have a touch of internalized weight bias, again, thinking we're not trying hard enough, or we're not good enough, or we don't deserve this because we're failing, because society has told us we're failing. And so I need to message to all the patients out there, like, you are worth it. And you deserve the same care that everyone else is receiving. You deserve to have feel the best you can, which might not be perfect, but to feel better. But yeah, the weight bias, and specifically right now around insurance, seeing a lot of insurance just throwing out denials and with randomness of why. Like, so when the indication, so we know Medicare sets the standard. Medicare doesn't cover anything for obesity or weight management in and of itself. That's changing hopefully soon. But when these new indications came out, like cardiovascular risk reduction, liver disease, kidney disease, and for obstructive sleep apnea, Medicare has put out a statement saying, we cover for these diseases like this. You can cover for this disease. And again, they set the standard for other insurance to follow. Are other insurances as quick to follow? Probably not, but it's been more than a year now, so they should be picking up. But again, because insurance is known for just saying no and expecting patients to take that answer and go elsewhere, they will say no. Or I've seen insurance, Medicaid and other insurance who should be covering these say, again, you don't have a current sleep study, or your severity of your sleep apnea isn't severe enough. But they're doing so without policies. When you get denied care, you should be given the policy stating like what covered, why you didn't, meet the criteria for coverage. And I'm not seeing that. The other one is saying the care has to be provided by a sleep medicine specialist or a pulmonologist or some type of specialist, and it can't just be by a primary care physician. And that is challenging because not all sleep specialists, I mean, it's challenging. And imagine when you're titrating up on the medication, you need to be seen on a monthly basis or checking in on a monthly basis. That is a lot of appointments that might not be available for a sleep specialist. So, but that's also not something they do. They don't say, people with heart disease or diabetes can only be treated by endocrinologists or cardiologists. Certainly, this is a healthcare system where primary care providers manage those other chronic conditions. So those are just some of the things we're seeing become barriers. And again, this is when patients and their doctors and providers have to push back against this. And there's really not a basis other than bias and just not wanting to provide the care, because when you think about the amount, 40% of Americans live with obesity, some people think, oh my gosh, it's going to be 40% of everyone wanting these medications or wanting this treatment. And that's not an accurate utilization rate. But to touch on the primary care, we've seen through my work with other obesity organizations, there are more PAs, NPs, and just primary care, internal medicine, and even hospitalists who are becoming board certified in obesity care. So it's great that you can find someone who is a primary care provider who also is specialized in obesity care and can really help you manage these treatment options in conjunction with any specialist that they send you to for additional testing or management.
Thank you for that.
That's great, Sarah. I do want to follow up one thing that Sarah said, and these are the questions that we get often when patients reach out and say that their insurance has denied coverage for tirzepatide or Zepbound, and how do they go about with the appeals process or what they need to do. So this is something you both are very familiar, I guess. In your clinics, you see that too. And again, just give us some tips, sort of what people can do if they encounter something like this.
Yeah, so we typically try to figure out the reason for denial because, as Sarah mentioned, something can vary. Like, if it's no sleep study within the past year, we typically will, unfortunately, it's annoying to go through testing, but if that's what it takes, we might repeat another home test that's more recent, or we document that sleep apnea really shouldn't have changed. So the old test is still representative of the patient's current condition, and it would sort of just be delaying care to repeat sleep testing. I've even run into situations where the sleep apnea was not severe enough, but that's because the patient has been on a GLP-1. So that's a situation where we write letters of medical necessity saying that what you're seeing is the result of the treatment. It doesn't mean that the sleep apnea is gone. It just means it's well treated with the GLP-1. So it really depends on the reason for denial. And we typically, working with your doctor to write letters of appeal, which, we're happy to do. We get very frustrated when the insurance doesn't cover it when it's needed. But yeah, it's a frustrating process.
30% of my job. So yeah, no, 100% agree. So first of all, as far as the insurance, the rules change every 3 to 6 months. All right. And so we're always adjusting to what the new rules are. A few years ago, before even before Surmount came out, before the sleep apnea study came out, we were starting these medicines and Medicare covered everyone. All right. Medicaid covered everyone. All right. So these are new rules that we need a second diagnosis, because guess what? These medicines have an FDA indication for obesity, which is a disease, right? And you don't need a second hit to be. It's an arbitrary ad just to make things harder. So let's be clear that this is an arbitrary addition to limit care to patients that do need these medicines and are appropriately treated. The rules are going to change in the next 3 months, and then the next 3 months, and the next 3 months. It's just part of how it is until these medicines get less expensive. and they are getting less expensive, but until they become cheap, insurers will continue to change the game to make it hard to get these medicines. Just like Dr. Tadros, I write a lot of appeals. I have multiple templates for appeals because we are used to many different kinds of denial letters, like this is now treated. Do we still need to be on this? Yes, you do. I can't even go through how many confusing, frustrating frustrating denials we go through. And anyway, so it's part of the job in obesity medicine. We are, as obesity practitioners, we are here to help you. And I don't think we're unique. I think every obesity doctor that's out there has dealt with the same thing, and is here to manage it. But a lot of it is getting appeals and then arguing that these are appropriate medicines for patients and trying to find a way to get people started on appropriate therapy.
Well, thank you for that, because that is certainly very frustrating, and that's not how it should be. But I guess right there is the need for advocacy, right? And especially patient groups like us that can help and work with you as experts in trying to change how things are, the healthcare is being delivered. We're up on the hour, so I just want to thank all our panelists for being here today. And I want to also encourage our audience to continue to engage with us. And if you have any other questions, please write to us at info@apneapartners.org. And again, visit our website, GSA, and OSC's websites. There are plenty of resources. And again, please write to us, and you have questions specific to Dr. Tadros or Dr. Wojcik, I will get those questions to them so they can come back with answers for you. And again, thank you all for joining today. And I just want to wish you all the best. And I just want to thank all our panelists for being here today. Thank you. And continue to engage in the Sleep Apnea Education Week until the end of this week.
Yeah,
Thank you.
thanks for having us.
Yeah. Thank you. Bye-bye.
Bye.